I'd like to welcome to the stage Bob Cusack, and he will be in conversation with Congressman Larry Bucshon of Indiana. He is the Vice Chair of the House Energy and Commerce Subcommittee on Health. Welcome, Congressman.
So first, I want to kind of start with some news on the day. It doesn't look like a supplemental is going to get done before you guys leave. Is that your take, and do you expect that the House to adjourn sometime later this week?
Yeah, I think that's my take. Unfortunately, for me personally, I think I've been a supporter of our efforts in Ukraine. I think we can't allow Putin to take Ukraine. He'll then go into NATO countries, and then we'll have our own men and women with their boots on the ground. I think that's the majority opinion in the Congress overall, on both across the House and the Senate. But honestly, from our perspective, I do think the domestic issue related to the southern border and that is something that is has been a barrier to getting compromise on the funding solution. So I think it's really unfortunate. I saw some comments coming out of the Senate yesterday saying that they're not going to probably address it before the end of the year, and so I think that's unfortunate. We should.
And do you think what would be part of the solution? Mitch McConnell has said the president should get more involved. We've talked to some members who've said the same thing.
Yeah, I think that's true. I think on big issues, you have to have leadership from the White House, and I think the White House has been engaged. But I think at the end of the day, big issues like this, it'll take the White House and the president being engaged directly to get this done.
You recently wrote an op-ed in The Hill claiming the Medicare physician payment system is broken.
Yes.
You come from the physician community. Tell us why it's broken.
Yeah, I will. First of all, I wanted to associate myself with the comments of my former colleague, Kurt Schrader, and thank you for saying that Congress can actually accomplish some things.
You don't hear that every day.
We miss him. We miss him on the Energy and Commerce Committee, by the way. So so I want to associate myself on his policy discussion too on drugs. I would agree with that. Well, there's a couple of problems. The pie is the same size all the time. We have what's called budget neutrality at CMS, where we can't expand the size of the payment pie. What that means is anytime we try to adjust payment for primary care versus specialists, we're robbing Peter to pay Paul all the time. So we have that is a big problem, and we need to address that. The problem is that's very expensive. The other issue is if you look at the situation with inflationary updates, hospital care, both inpatient and outpatient, get annual updates based on inflationary measures. Providers do not. So if you look at the long-term graph on that, you see that hospitals and others in the healthcare system, based only on inflation, is going like this. Provider reimbursement is flat. So if you consider what our inflation has been the last couple of years, even if we stay with no adjustment, no upward adjustment to the fee schedule, we're losing. We're losing a lot of money. So the problem with that is that practice costs are driving this. So as practice costs go up, and as no inflationary adjustments for the provider reimbursement don't go up, my concern is access. And I represent rural America. You're seeing it more and more difficult to maintain medical practices in rural America, and that's a problem. And underserved urban America. Both have very similar problems for slightly different reasons, but the concern about access and quality is there if we don't fix this. Over the last 20 years or so, just based on the inflation alone, providers out there are losing over 20%, just based on no adjustment for inflation. So I have legislation 2474, which is bipartisan, with Dr. Miller-Meeks on the Republican side, Dr. Ruiz and Barra on the Democrat side, all doctors, that would adjust the fee schedule annually based on the Medicare Economic Index, which is an index based on practice costs. And, we put that out there. The issue is paying for it.
Right.
We don't have a CBO score yet, but let me tell you, we've created some conversation.
And do you think you'll get that CBO score? because obviously you need it.
I've asked my leadership for that, so I'd have to defer to that. On issues like this, I think it takes prioritization by leadership.
Right.
And the reality is they've got a lot of priorities right now, right?
Yeah, yes.
And
Speaker
so
Johnson has a lot on his
he has a
plate,
lot
yes,
on his
yes.
plate, as does the Democrat leader. Either side could ask the CBO. The issue is how do you score this over time when inflation changes, right? So next year, if the inflation is 0, then there's no update for the fee schedule, right? If it's 10%, there's a 10% update if the MEI goes up by 10%. So I've talked to the CBO director about this a number of months ago. We're hopeful that we can maybe use the average inflation over a period of time and just get an estimate. Getting an actual number would be difficult.
What's and I used to cover CMS and the SGR and the fee schedule, all that, and it's a lot of alphabet soup. But what's the impact of it, especially with an aging population?
Oh, it's huge. I mean, I mentioned before, access.
Access, yes. But what do you think will happen unless policymakers make some serious fixes?
Well, I think you're already seeing it. Okay. First of all, rural and underserved urban America. Okay. Less and less providers want to practice in those areas.
Can't get an appointment, can't get a doctor.
Right. So
have to travel long.
You can't get appointments, you can't get a doctor. So it's an access issue. For me as a healthcare provider, when I look at public policy, I say, does it accomplish a couple of goals? Does it accomplish access to everybody, for everybody, regardless of their zip code? And does it impact the quality of healthcare that people can get? And we clearly, your previous panels have discussed, we clearly have disparities across our country that need addressed. So as reimbursement doesn't keep up, which it hasn't, you're going to see less access in those areas, particularly rural and underserved urban America. And again, that's just not right. We can't have that. And so we had testimony. It's not just my opinion. We had testimony, and there was an economist a couple of weeks ago that said seniors, about 40% of seniors are having difficulty finding a primary care physician.
40%.
That's what he said. Well, what he said it in a positive way. He said, the system is such that 60% of America's seniors don't have trouble finding a physician. And so when it came to my time to question him, I said, okay, so what you're saying is 40% of the people, and all you have to do is talk to your grandparents or your parents if they're looking for a new, say their doctor retires, right? This happens all the time. And then they start looking around, they go, okay, who takes Medicare? Can I find a primary care doctor? So that's what happens if the fee schedule doesn't keep up. Now, there's people that argue, say, hey, doctors do pretty well, financially. And that for the most part can and is true. The problem is like every other job, so to speak, if the level of expectation of what your level of training and expertise, the level of expectation on your compensation isn't there, then less people will do it. It doesn't matter whether you're an engineer, a lawyer, or whatever. If you drop the expectation for the reimbursement, so to speak, or the pay, and I think we have to look at that reality. Where are we with that? Well, we can't get doctors in rural and underserved America. And why is that? And they'll tell you, we've got a high educational debt coming out of medical school. Then we got to do our residency. We got to defer our payments. And then if you look at the reimbursement, I just can't afford to go to underserved urban America or rural America and practice. And so that's the reality. And that's what we have to address. And there are some that say, well, we understand that, but we still think that we need to control healthcare costs by cutting provider reimbursement. I'm talking about physician provider reimbursement. And that hasn't worked. We started that in the late 80s, right?
Yep.
In the late 80s, we started adjusting the fee schedule downward. And does anyone in this room say that we're controlling healthcare costs in the United States? We're not. Hasn't had an impact. All it's done in my opinion, is decreased access and ultimately will decrease quality.
What are you watching with CMS's implementation of the drug pricing law?
Well, first of all, I didn't vote for it.
Right.
And for a variety of reasons, some of the reasons that you already heard from your previous panels, right? Concern about access to not only current medications, but future medications. And that's not my opinion. I think Congressman Schrader pointed out that CBO has estimated that innovation will drop, and over time, you'll see less medications developed. And so the big concern for me on it was, what is it going to do to access to quality medications, not only currently, but in the future? Some of the medications mentioned by one of your cardiologists on the panel that are high cost but very effective, if they're on the list, do the companies continue to make the medications if the negotiated price drops below their ROI for that product? The answer is no. They won't do that. And I think you also have to look to Europe, and don't quote me on the exact numbers, but if you look at France and other countries, the availability of medications on the U.S. market versus what you can get if you're in France is about 50%. They can only have access to 55% of the medications that are on the U.S. market. And why is that? Because the government won't pay for it.
Right.
And so that's my main concern going forward. And let me just comment on the penalties. I think the 95% penalty on your gross revenue for medication is going to be proven to be unconstitutional based on the takings clause of the Constitution. I mean, you can't just tell a company, look, if you don't take a price of 0, which was pointed out is the lowest price, then for the Medicare system or Medicaid, then we're going to take 95% of your gross revenue from that product for the rest of the market. Number one, the drug will drop off the market. Number two, if they do that, I firmly believe that's a takings clause. The line in the Constitution about the government taking without due compensation your money.
I want to get back to your legislation, and it doesn't get the headlines, but you do have, you mentioned one bipartisan bill. You have a couple of bipartisan bills that are in the mix right now. What's the strategy in this polarizing time as we head into an election? Can you attach some of these, again, you mentioned the one bill passed by voice vote, so basically unanimously in the House. That's rare.
Yeah.
What's the strategy? Attach it to a fiscal bill that's moving next year? Can the measures move that quickly?
Yeah, I think the bigger legislation, adjusting physician reimbursement based on the MEI, the Medicare Economic Index, is something that's going to require some more work.
Right.
I mean, we know it's costly, it's expensive. Ultimately, it needs to be accomplished. So I don't think you'll see action on that. But I'm also working on bipartisan things on prior authorization. Mm-hmm. Last Congress, we almost had it across the finish line. The CBO came out with a score at the last minute, really, and killed it in the Senate after it passed in the House. Let me just comment on the CBO real quickly. Sure. On how they score health care.
Yeah.
I disagree with how they score health care, and I've had this conversation with them. They don't project future savings.
Like prevention.
Correct.
Right, yeah, I've heard this complaint before.
This is and the other thing they did, like on my prior auth bill, is unfortunately, HHS Inspector General came out and said on MA plans that some of the plans were denying claims that traditional Medicare would be paying at a certain percentage. And so when they scored the prior authorization bill that's trying to solve part of that problem, they scored it at what they're currently doing, not what the statute says they should do. So they set the baseline at what is currently occurring. And then when we tried to fix it and make it that people comply with the statute, they said it cost $16 billion to make people actually follow the law. So you see, that's one area where the CBO doesn't score properly, but they don't score future savings on preventive care. And they say the statute doesn't allow them to do that. And I know we're limited on time, but let me give you a big example that I always give people. The medication that cures hepatitis C, okay, came out, extremely expensive. There was a debate, hey, should we pay for this? Because, oh my gosh, scoring this a 10-year budget window, which is what Congress does, that's going to be a ton of money. because this thing's, I can't remember the cost, right, to get an ROI for the company that developed the product. Except for the fact that if you score it in the out years, it prevents chronic liver failure, it prevents liver transplants, it prevents multiple hospitalizations.
Outside the 10-year window.
Outside the 10-year window. And here's the most important part. It makes people healthier. They live a more productive life for them and their families, right?
Yeah.
And how do you score a person who can now have a productive life, you know, and how do you score the value of that? Well, we have to figure that out, because otherwise we can't fix some of these things in healthcare. We can't. We can't pay for new innovative products, whether that's medications, whether that's medical devices, because if we score them on a 10-year budget window, it costs a bunch of money, but we have to have the ability to say, okay, here is the out savings to the system, which I would argue would be probably 10 times what the initial cost would be. So that's my challenge on healthcare, and I'm working on it.
A lot of challenges ahead.
Yes.
Congressman, thanks for joining us.
No,
Thank
it's
the
been
Congressman.
a pleasure. Thank you.
Appreciate it.
Thank you very much.
Appreciate it.